Mixed cannulae, expanding performance standards. High-performance cannulae for direct and femoral cannulation in minimally invasive cardiac surgery. LivaNova's complete range of mixed dedicated products allow easy and reproducible procedures. The portfolio includes the sutureless aortic valve Percival, Memo 4D for mitral valve repair, the HeartLink system for assisting the perfusionist in applying goal-directed perfusion therapy, and a broad choice of high-performance dedicated cannulae. LivaNova's range of cannulae suit every cannulation technique for minimally invasive cardiac surgery. Venous and arterial femoral cannulation can be performed using the WRAP venous cannula and the EZ-Flow Duo. For arterial direct and venous femoral cannulation, the EZ-Flow aortic cannula and the WRAP are available. For venous femoral access, the LivaNova WRAP cannula features a dual-stage configuration for optimal drainage of the inferior and superior vena cava without interfering with the right atrium. The high-flow dynamics of WRAP improves the capability of drainage with a low pressure drop. An optional Sellinger dilator kit is available to perform percutaneous insertion. The LivaNova EZ-Flow Duo cannula is designed for a safe and smooth femoral arterial cannulation. Its conical dispersion tip design allows a more gentle flow in the femoral artery, and its red cap avoids blood backflow during obturator removal. A dilator kit for percutaneous insertion is also included with the cannula. EZ-Flow cannulae are designed for safe, reproducible, direct aortic cannulation and include a malleable stylet to aid cannulation insertion, facilitating bloodless introduction into the aortic arch, as well as a special conical dispersion tip for a more gentle flow in the vessel to reduce shear stress.
The point-of-care program at Huntsville Hospital is approaching its 20-year anniversary. As we began to grow as a hospital and provide more complex services to our community, the need for point-of-care testing became very clear in our organization. Many of our departments consider the EPOC device to be crucial to their ability to quickly move their patients from entry to the hospital to procedural room. It helps them monitor the patient's status during their procedures and post-procedure, so it's very integrated into our entire continuum of patient care. If you have any patient population where blood management is crucial, then a point-of-care device is very useful in those types of settings. It can provide a quick result on a very small amount of blood, and that is really important in some of our patient population.
We are starting a new process where we're going to screen our patients on the floor for sepsis. The patient can look and actually feel okay. They will show us signs and symptoms of sepsis. So what we do when they show these signs, we get a lactate level.
Lactic acid is a product of the sepsis cascade. So with sepsis, the inflammatory light switch goes on, the cascade starts churning, and unfortunately, once it starts going, we have to stop it. It will not stop on its own. The faster the lab draw, the faster the lab results, the faster you can act on it.
The process in the lab is what the process is. It just takes a certain amount of time for the instruments to run those tests.
I mean, we're talking 30 minutes even on a stat because that's the process. That's just how long it takes. There's not really anything you can do about that. For every hour you wait to give an antibiotic, the mortality for that patient increases 8%. So now that we have the handheld device, the nurse can get those results within a few minutes, and we know how to treat that patient. If a patient is going into septic shock, we do not have minutes to spare. We have got to get it done quickly. So when you get the little beep from the EPOC that says your results are in, you go with it. You don't even think twice about it. You're like, this is good. This is what I'm going to do for this patient. The next steps are clear.
I think our mortality on the initial floors dropped by almost 50% in the first 3 to 6 months. At this point, we're about hospital-wide. I think we'll be hospital-wide another 2 to 4 months. So this has become a huge program within our system.
Without the EPOC device, it would really be hard for us to get everything done in the timely manner. So it's really helped us to get our program going.
I mean, whether you're a surgeon, whether you're a medicine doctor, whether you're a dermatologist, you want to be able to do things in a timely fashion so that you can be most effective.
This really makes a difference in patient outcomes.
And good morning, everyone, or good afternoon, or good evening, depending on what part of the world you're in. Welcome to our PerfWeb program. This is PerfWeb number 54, Tammy Sparacino Journal Club 16, and John Ingram Knowledge Nuggets 4. So I got them all. I got them all, finally. So welcome to the show today. We want to make sure we do our due diligence and thank our sponsors, LivaNova, Siemens, and also HET. We do also represent HET, so just so you know, we are in Houston, Texas. Our company is really here. We're a smaller regional but bigger local group, if you will. We are hiring. You can go to het.us and learn about us as a company and submit your CV, and also not only perfusion, but we're looking for autotransfusion. Now, it's not easy to work for us because we're very selective. We are looking for people who are great team players, who enjoy education also, and who can work with some great surgeons, very independent, very collegial, great opportunities. So check us out. Social media, please make sure that you like, follow, and share us on the Facebook, the Twitter, and the LinkedIn, and also subscribe to our YouTube channel. That's one of the most important things. And also give us the thumbs up, click the bell notification so that if we're doing something, we add something on at the last minute, you can be a part of it. You'll get a notification of that. And that is going to start happening more and more as we move forward. We're still adding new things to our program. You can reach out to us on the program at perfweb.us and perfusioneducation.com. Perfweb.us is more of our schedule. You can look at our upcoming schedule. You can also look at past events, all the way going back to the history of when we first started with PerfWeb. And then Perfusion Education is a free site. You can join for free. You have access to everything. The only thing you would pay for, and you can earn all of your CEUs through us. So I want to make sure you understand that. For those of you that are having challenges going to meetings, and this whole thing started, Perfusion Education started. Can you go to the would it mess you up to go to the 3-panel view real quick? Because I want to bring everybody in on this if I can. Or would that mess you up? No. Here, just one second, because I still have to finish the other part of this. But there's everybody. So I'll introduce the faculty out of order, if you will. Tammy Sparacino, we all know her. She does the Tammy Sparacino Journal Club. We have John Ingram with John Ingram Knowledge Nuggets coming from Orlando. But PerfWeb really started because I understood, at least I started to recognize, that there was a tremendous amount of pressure coming from our colleagues being able to get away, get CEU budgets being slashed. There weren't enough staffing was an issue. People couldn't get away, couldn't get coverage. And the online environment that existed, including with us in the New Orleans conference, was basically doing a live conference and also airing it. And it wasn't, it was good, but it wasn't nearly as polished or as seamless because it wasn't made for being aired.
Right.
It was an add-on. And that's really why I started this. It just so happened that COVID happened. And when COVID happened, we had already built the studio. We had already started with this endeavor. And it really put us in a very good position. But I think we have continued to evolve. But that's how the whole thing started. It didn't really start because of COVID. It just happened to be really a good thing to have when COVID happened. So
Now, when was the first PerfWeb?
good gracious, I think that was well over 2 years ago. 2 years, over 2 years ago. Yeah,
Yeah.
we're on like 54 or something like
Yeah.
that.
Yeah.
And that's not 54 days. You know, that's 54 individual programs, some of which were multiple day. I'd have to go back and look the exact date. I don't know, but it was like probably 2 years and a few months ago. So anyway, it's been really it's been a wonderful experience. I've really enjoyed it, and I appreciate the support. We've really grown a lot through this period of time, and want to continue to evolve. That's why we keep adding these new programs. And I've got an announcement coming up, not today, but there is an announcement coming up about some new stuff that we're going to be doing that I think is going to really revolutionize what we're doing with this program. It's going to expand it tremendously. So let's go back and let me finish the stuff. I'm sorry. So you have the perfweb.us, perfusioneducation.com. When you see this icon, the phone lines are open. You can call in, and you can either be live on the air, or you can use the YouTube chat, or whatever it is that you would like to do. And then I also want to talk about our new MediWeb app. So it's the Critical Care Perfusion app. And there's actually two different apps. If you look at the screen there, here, we'll get it there in just a second. You should be able to see, we're almost there. Well, yeah, that's where you go get the app, but then we're sharing my phone, so you should be able to see the app. If not, I'll just move on. Oh, there it is. Okay, good. So if you look up at the top left, you'll see two icons. I don't think they can see it. There it is. That's great. That's perfect. Perfect. So the critical care, and there's an IV medication calculator, but the IV med calculator is actually in the critical care app. So I don't have to show you both applications, but that's what they look like. And you have a perfusion section, ECMO section, hemodynamics, clinical calculators, IV calculator, and conversions. We'll just go ahead and do perfusion. I did this last week. We did it a little differently. But if you scroll through it, you can see all of the various things you can do. And let's just say you're doing a case and you need to know the circ arrest time. Maybe it was an unplanned circ arrest. You can go there, and these nomograms will tell you if you're at 28 degrees, your arrest period is 10 to 15 minutes is what is considered safe by the literature, by the data. And it gives you some idea. If you want to know, for example, what your O2 transfer rate is on the oxygenator, let's say your saturation comes back 97%, and you're thinking to yourself, well, is there something wrong with my oxygenator? And you look at your SpO2. Now, inherently experienced perfusionists are going to know this, but let's say your saturation comes back 62%, and your hemoglobin, I'm just going to use this number, we're going to make it high, and your flow, because all these formulas are predicated when you look at the nomogram or the MFU from the manufacturer based on a hemoglobin of 12, so you know that. So I put that in for the sake of this discussion. But let's say it really is going to be more like 8 or maybe 7, maybe even lower, and you're flowing 4.5 liters a minute, you're going to have an O2 transfer rate. I'm sorry, it's got to be 4,500. It's in mLs. There you go, 253. So you know your oxygenator, if you look at the MFU, is going to have an O2 transfer rate somewhere around 200 to 250 milliliters per minute. So if you go in here to the hemoglobin and put it more realistic hemoglobin of 7, 147. So you know that your saturation of 97 is not based upon, you're at 100%, but it's not based upon the oxygenator not working. It's based upon your SVO2 being too low, and something else needs to happen there. You can calculate SVR, mean arterial pressure of 70. Your CVP will say is 2. Your cardiac output is 4. And it can be liters per minute or milliliters. You just have to make sure you put the right number in. And it's 1,358. It's in green, so you know that it is normal. Red would be abnormal. And if you click the little eye icon, it'll give you various information about that particular section, the equation, the parameters, what's considered normal, etc. So all of that is within this app. It's only $2.99. I need to sell 1 million of them so that I can retire, and I think I've got about 999,000 more to go. So anyone wants to buy, be great. And there's the IV rate calculator. I'll just do a very quick, let's say you have an infusion rate. Your dose is 5 mics per kilo per minute, and the patient weighs 100 kilos. This is great for nurses in the ICU. You have 400 milligrams in a volume of 250, and based on that information, you calculate your IV rate needs to be 18.75 milliliters per hour. So it gives you that information very quickly. I know the iMed pumps do that, but if you just needed to get that calculation done for some reason, it's there. So the apps are independent of each other, but both apps exist in the critical care perfusion app. All right, so that takes care of that. So make sure you go buy the app today, please. What do I need to do next? Podcasts. Make sure you go check our podcasts out. You're driving in the car. You want to listen to us. You don't have time to watch us. You can be listening live, and you can even call in from your car. So all of those things are options for you, and you can view us on whatever your favorite streaming service is. I know there's Podbeam, and there's Spotify, and there's various other ones. I really don't know all the names of the different podcasts, but you can look us up, I believe, on PerfWeb and find us and be done with that. So I've already introduced our faculty. We're going to move right forward with Tammy Sparacino's Journal Club, which is a commentary on ECMO Cannulation for postcardiotomy shock, and it's sort of pithy in that it's asks the question, is location really everything? So Tammy, welcome, and the floor is yours.
Thank you. Welcome, everyone. Thank you for joining us today. As Joe mentioned, this article is about ECMO cannulation, specifically for postcardiotomy shock. It was published in the Journal of Thoracic and Cardiovascular Surgery. It was published in November 2019 for an article that would be published later in 2020. And I hope you'll forgive me. I'm not going to try to pronounce these names. So this article is written by Dr. M and Dr. K.
I completely understand. I looked at the names too.
Yeah, I'm not very good with names, and I'd hate to not say them correctly. So again, we did a commentary from this on the, I believe it was last Journal Club, from this same journal, and I love that they always have a central message. You know, just if you had to summarize in basically one sentence, they do that here. And this commentary is going to be talking about peripheral versus central cannulation for VA ECMO. The influence outcomes in, does it influence outcomes in postcardiotomy shock greatly? It remains unclear whether this is a true cause or simply a surrogate of patient level risk. Okay, obviously why this paper was published is they wanted to look at a specific study, which I'll go ahead and, just like I did last Journal Club, bring up that specific study article that they were talking about. And they wanted to see, is this a real, were the results that the study came up with, were they a real causation of cannulation, or was it just a byproduct? And how they did it was by reviewing this particular article. So this is the original article, And you can see it was also published in the Journal of Thoracic and Cardiovascular Surgery in November of 2020. And it was looking at specifically at a center where they were going to compare all of their cases for peripheral versus central cannulation. Then in addition to that, they also did a systemic review and meta-analysis. So they were very thorough in everything that they were trying to do here. Their abstract was just a little bit of background. They, forgive me, let me go back one. And you can see it's by Dr. Maniscalco.
Yeah, that was easy.
I got that one.
We worked with Dr. Maniscalco.
Yeah, so it was kind of easy.
And I thought that was pretty cute.
Yeah. Okay. So they hypothesized that cannulation strategy in VA ECMO could play a crucial role in the perioperative survival of patients affected by postcardiotomy shock. Okay, so just briefly, we'll go over this article just a little bit so you can just understand the commentary a little better. They looked at, in January 2010 through March 2018, 781 adult patients receiving VA ECMO for postcardiotomy shock at 19 cardiac surgery centers that they retrieved from the Postcardiotomy VA ECMO Membrane Oxygenation Study Registry. They also did a parallel systematic review and meta-analysis through PubMed.
And may I just mention something? So for maybe our younger colleagues out there, postcardiotomy shock is essentially failure to wean from cardiopulmonary bypass after some type of heart surgery, whether it be coronary bypass, valve, or combined procedure.
Agree. Yes. Sorry, I should have gone over that real quick.
I'm just doing that for some of our younger colleagues.
Okay, and so here are their results, and you'll notice that most of their, about 30% were central, and most of, at 68%, were peripheral cannulation. They had, they went over, this is actually where they talk about the main indications for VA ECMO were failure to wean, cardiopulmonary bypass 38%, heart failure following cardiopulmonary bypass weaning at 48%. Then they also looked at, let's see, I'm going to scan down, go over some of these, skip over some of these statistics, but you can see that they said that the robust analysis after inverse probability treatment, weighing by propensity scores, demonstrated that VA ECMO was associated with greater hospital mortality, reoperation, VA ECMO, central VA ECMO, there we go. Central cannulation VA ECMO was associated with greater hospital mortality, reoperation for bleeding and tamponade, and transfusion of more than 9 RBCs. Their systemic review provided a total of 2,491 individuals with postcardiotomy shock treated with VA ECMO. This is long, so I got to go to the next page. Their pooled prevalence, hospital 30-day mortality, and overall patient population was 66.6%, and with the unadjusted analysis confirmed that patients undergoing peripheral VA ECMO had lower in-hospital 30-day mortality rates versus the ones going central cannulation. Adjustments for important confounders did not alter their results.
Now, I found that fascinating.
I did too, that last sentence, right?
Because that too, but I have, and I do think that there are some other data within this, but just predicated on this, it sounds like peripheral cannulation is better than central cannulation, but that is the complete opposite of what I have always believed. But I think there is an interesting twist to this article, so I think it'll be interesting to hear the rest of this.
Okay. So their conclusions, remember, this is the original article that the commentary is about. The conclusions from the original article: in patients with postcardiotomy shock treated with VA ECMO, central cannulation was associated with greater in-hospital mortality than peripheral cannulation. Okay. So before I go into author's conclusions, actually Joe took a real interest in this one, and if we could bring up Joe's slides now, he's got some commentary on the commentary.
Yes. So you want to throw those slides up?
Yeah.
So I thought this was very interesting. So this was the original central message from the article. Peripheral vein versus central cannulation via ECMO influences outcomes in postcardiotomy shock greatly. It remains unclear whether this is a true cause or simply is what they meant, a surrogate of patient level risk. So go to the next slide. These are some of the thoughts that that these authors had, the people doing the commentary.
Correct.
The Dr. M
and
and Dr.
Dr.
K. Right. And these are very key points. And
They
there's
are.
just 2 slides, and so it's relatively short. But I want to read it thoroughly. Although a robust statistical analysis was performed, the conclusions should be interpreted with caution for the following reasons. And that when I first read the article, in the very beginning, I first was like, well, wait a minute here.
Right.
Central cannulation is better for a whole host of reasons. But they first, in fact, he compliments the people on their study.
He does. It was very thorough.
It was very thorough. But first, the absence of uniform patient selection and VA ECMO indication criteria, as well as varying postoperative management algorithms across institutions, introduces a significant source of bias that simply cannot be measured and accounted for in the multivariate propensity score analyses. Secondly, the decision made to retain the central cannulas after CPB, cardiopulmonary bypass, may reflect the surgeon's aversion to cannulate peripherally for a number of reasons: small vessels, extensive iliofemoral occlusive disease, advanced shock and vasoconstrictive states, all of which confer an increased risk after cardiac surgery. This is corroborated by the fact that there were more patients in critical condition with a salvage indication who underwent a central cannulation strategy. In addition, the patients with central cannulation had a similar rate of lower limb ischemia to that among the patients with peripheral cannulation, which I also found very strange, but I think there is an explanation for that, which has to do with high pressure usage and basically clamping down, plus the smaller vessel size, iliofemoral disease, all of those things that he just elucidated.
They're all likely contributing.
Absolutely. And of course, now with our fancy SFA, distal perfusion catheter techniques, which work very well, I think limb ischemia from femoral arterial cannulation is much more reduced now than it ever was in the past. But this, which could be the result of a more advanced shock state, which in turn translates to a higher risk of mortality. So you see, they're doing central cannulation because, well, peripheral cannulation is really not a good option, and that patient is actually sicker anyway. So, and that's a confounding element to everything. Third, there was an extremely high overall in-hospital mortality among patients with central cannulation strategy exceeding 70%, and there was a higher use of peripheral cannulation in higher volume centers. And they bring, this is a very key point. The same research group also has reported that the volume risk relationship is crucial for VA ECMO, and that centers with higher experience had a 27% lower relative risk of in-hospital mortality than lower volume centers. Basically translating into, if you don't do ECMO on a somewhat routine basis and have that experience, you're simply not going to be good at it.
Right.
And it's generally going to be a real disaster. And transitioning to ECMO with the intention of going from the operating room to an ECMO transport team to an ECMO center is a much, I think, better option than sitting there trying to transition a patient to VA ECMO in a place that hasn't done one in 3 years, 5 years,
Even
2
one
years,
a year.
even one a year. It's nobody has the requisite skill to manage those patients. They usually just don't have the infrastructure, the multimodality approach towards the interdisciplinary resources that you need to manage that kind of acuity level. And so go to the next slide. And this is what ends it up. The piece of the puzzle that is unfortunately still missing is the mechanism by which peripheral cannulation strategy could potentially improve survival. And this is why the article was so confusing to me. Theoretically, a peripheral VA ECMO is associated with increased afterload, left ventricular wall tension, and myocardial oxygen consumption as a result of incomplete left ventricular unloading. Central cannulation strategy allows a higher degree of LV unloading because central venous drainage affords the option of direct LV emptying through a left-sided cannula, like a right superior pulmonary vein, a vent, whatever you want to call it, even an LA catheter. This option was used in less than one-fifth of the central cannulation groups for reasons that are unclear to these commentators.
Yeah.
Correct, yes. Massive transfusion cannot be the sole explanation for the relatively poor outcomes observed among patients with central cannulation because almost 65% of patients with peripheral cannulation also had massive transfusion in the study of Mariscalco and colleagues. The answer seems to lie in patient-level factors incompletely adjusted for in the multivariate analysis, which translates to an important selection bias.
That's
so
right.
basically, I think what happened, and you can take the slides away, I think that was the last one.
That's it.
I think what happened here is that they, so where we're going. Okay, we got it.
I'll get us to.
You'll get us to where we need to be.
Yeah.
That if you take a whole bunch of places and only a few of them are experienced ECMO centers, and you add all of these other experiences within that, it's going to very much skew the effectiveness or ineffectiveness of ECMO and the type of cannulation you do.
Right.
I believe central cannulation is far better than peripheral cannulation. Now, still approximate the skin, get good hemostasis, have the catheters, the cannulas tunneled so that you can close the skin versus leaving the chest open. With an LV vent, it really gives you a much better hemodynamic picture in dealing with that patient. But you have to spend the time to get good hemostasis. You have to manage it before you move to the next step and know how.
Right. Let's talk about this for a minute. We can take the slides down and just put the three of us up. John, what are your thoughts?
Hey, good morning, guys.
Good morning.
Good to see you again.
Hey, John.
Hey, guys. And yeah, there's a lot to unpack here. It's a great topic, Tammy, once again. And I think for the benefit of the audience, the listeners that we have and stuff is what the commentators there said was a big part of what I was gonna bring out. But one thing I had a question before I get into a comment was, at what point, when you're trying to wean off bypass, do you go from a central cannulation to a peripheral cannulation? I'm a little perplexed about how that happens.
I mean, I think it happens because what will happen is they'll come off pump, they'll try weaning, and they'll limp off bypass, and they'll be on all types of pressors and inotropes and dealing with that, and they'll want to get decannulated, and then they get decannulated, they gave the protamine, the patient is now obviously not going to make it, and then they convert to a femoral cannulation. So I think that happens not too infrequently. And so I think that's one. I think two, I have been involved in cases before where they have done that. We have been on pump. They have gone ahead and inserted femoral lines, gotten wires in and lines, put the cannulas in, came off bypass and converted to peripheral because they wanted to close. It was
their objective to close the chest.
Yes.
Yeah.
Of course, those were earlier days. It's very uncommon for me to see that now, but I would say that I probably have still seen that within the past 3 years.
I think I've seen it in scenario 1 where you did everything you could, you made it off bypass, but maybe you don't even make it out of the room, you know.
Yes, correct.
You've already put them on everything you can, and chest is closed, and yeah.
And actually, I think that's where a lot of people get into trouble, is they're so determined to get the patient off pump when it's pretty clear they're not going to come. They're not going. If they come off, they're not staying off.
They're not staying off. Right.
And then I think you need to make a decision earlier versus giving all of those drugs, because as you're doing that, you're just really what you're doing is more injurious, as opposed to, we're not coming off, let's just rest, let's go through this process. There seems to be this expedited, you know, sort of rush to do something else, whereas I think the more seasoned surgeons and the more competent, if you will, or when I say competent, I mean in terms of experiencing
of this particular issue, right,
tend to slow it down and take it step by step by step.
And don't you think that too, just even doing let's come down to, you know, just a couple liters and rest for 10 minutes on bypass, I don't see that much anymore. And that used to be the way that we would kind of test to see how are they going to do? Can they manage this? If they have just a little more recovery time, we'll be able to come off. But I don't tend to see that much anymore.
I don't either.
Yeah.
I mean, I think we've come to understand you're coming off or you're not coming off. And I have my own technique for coming off bypass. You know, an empty heart always beats well, you know.
Yeah.
And unless it's just dead, you know. But
right.
I mean, a sick heart will beat way better empty. So when I come off bypass, what I normally do is give them a period of luxurious flow, and then I will empty them out completely, and I'll take the venous line and go ahead and really come down on it, and but I'm coming way down, and I've got the flow down as well, and I'll let the heart continue to fill. And once I see no further increase in systolic pressure for any aliquot of volume, I stop. And then if it is volume, they just need a little more, push a little more. But I try not to fill the heart to the right point with forward flow, because I just think that they're working against each other, and I'm not really able to assess how much circulatory support is coming from me in terms of this mean pressure or this systolic pressure versus how much is coming from the actual heart. So, you know, my way of doing it is to do it starting off empty and getting my venous line almost completely occluded, and sometimes completely occluded depending, and slowly infusing that volume. But I do it after I've given them a period of some luxurious flow, just as a baseline, kind of like turning the vent up to 100% before we go and change the ECMO circuit out.
Right.
That's what we need to do.
Exactly.
So, so if I could, yeah, that's a good point, Joe. So the interesting thing is, I mean, I honestly cannot remember. You're saying it's been a few years since you've seen it, and maybe it was long ago. I don't remember any case I can think of where we had an open chest and we got the patient off, and we, instead of just opening the chest right back up and putting the cannulas back in, did we sit there and try to go fem when we basically had a chest ready to go. I just don't remember if I've ever seen a case like that. But what's interesting here is that 2/3 of their patients in this multi-center study ended up on peripheral cannulation ECMO after postcardiotomy.
Right.
And that's strange, because I just can't recall a case where I've ever seen it happen as you were describing. I don't doubt that it happens, but perhaps in this environment, I guess this was a foreign paper. Maybe there's a real push to have the chest closed.
It's from Canada.
Canada.
Mm-hmm.
I mean, perhaps in this region
Canada,
or this country, there's a big push
No.
to have the chest closed.
Actually,
And,
they just did this. I just got a message
Hold
from
on.
somebody at Texas Heart
Oh.
that said this was a scenario that they experienced yesterday, was coming off bypass
Oh.
and converting to VA ECMO with peripheral cannulation.
Well, can you ask them, or I guess we can ask them, they're watching, what was the reasoning behind that?
Yes.
Was there any specific reasoning why you wanted to go ahead and convert to peripheral?
Let me see. Alex, can you call in? Can you
So-
call in?
Yeah, go ahead, John.
Yeah, while Alex is calling in, hopefully, and the commentators, I think, pointed out what really was stuck out in my mind the most, which is it's not intellectually appealing to have a failing heart, a heart that's stunned and in acute failure, and then put in a venous cannula whereby you're probably going to incompletely unload the heart and then flow retrograde towards the heart,
Agreed.
Towards the aortic valve. Those two things are disadvantageous as to what you're trying to accomplish, which is to rest the heart. Like you said, Joe, an empty heart beats great. Well, an empty heart is beating great because it's not working hard.
Right.
And it's getting
not having to
perfusion
squeeze.
without
Right.
having to work, right?
Yeah.
And
I mean, there's no question you're increasing ventricular wall tension and
Right.
decreasing myocardial coronary perfusion by virtue of that distension. Not to mention, you've got to worry about LV clot. Not to mention, you have to worry about pulmonary edema. I mean, it all ends up just
ischemia. I mean, there's lots of
different issues. I just think central cannulation with, now, if you start off VA ECMO with a closed chest, pre-sternotomy, being in the chest, median sternotomy, then of course, that's a different issue.
Sure.
And you can put an Impella in, but patient had right-sided distension, so the team believed a few days on ECMO support would help the patient. So they were doing it for more right-sided support, which is a different phenomenon than left-sided failure.
It is.
And that's a very good point, and I think that we didn't even mention that. So Alex, thank you for giving us that information, because sometimes with right-sided support, you don't have to flow that much.
Right.
You just need to flow enough to keep that right side decompressed, and it does beat a lot better. So good point.
Yeah. Okay.
And that actually brings up an interesting point of, if you guys have ever worked at places that generally don't put a swan in for their open heart surgeries, you can diagnose right ventricular failure, but it's a heck of a lot more clear and easy if you can see what's happening on a swan.
Yeah, there's no question.
Agreed.
No doubt about it. I completely agree. Now, echo is the best.
Right.
If you have a TEE, now the transthoracic can see it also, but
don't you find that, I think we have TEE available on all of our
hearts
Yeah.
have TEE, yes. But I think that some of our places we use swans on everyone. In fact, John,
but some of them we don't.
Some of them we don't. But I think we should be putting swans, CCO swans, in everyone who has VV ECMO. I think we're really missing out on a lot of important information, which I'm going to discuss in April, having to do with, we're doing VV ECMO, we're looking for a therapeutic goal, but we have a mechanical device that can only flow X, whatever that X number is, based on the system and cannulas and various other factors that are involved. But if you don't know their native cardiac output, it's hard to calculate how much of their deoxygenated blood is mixing with mine, and what can I do differently to help this situation? Do I need a second circuit? In fact, we have that patient that just recently got transferred to those guys, by the way, at Texas Heart.
Oh, yeah, that's right.
That they have that patient. I know, John, this is something you do a lot of. They have them on 2 VV ECMO circuits, two complete circuits, 2 separate cannulations, and because the patient is 29 years old,
hyperdynamic,
and hyperdynamic and healthy otherwise, a muscular 29-year-old who has a very high native cardiac output. One system just cannot cover him. And so, and he's a lung transplant candidate. He's one of the last, and it's such a, it's a good thing that he is where he is and has a chance, but it's so horrible to think that this is a patient who is going to be one of the last fatalities, well, let's not hope not, I shouldn't say that, the last of those afflicted with COVID lung, now that things seem to be improving at such a dramatic rate. It's really a horrible situation.
Really is.
But I probably shouldn't have, I need to retract that. And he's one of the last afflicted, but I think he's going to have a good outcome. I hope for it. I pray for it.
I hope so. I hope so too. John, anything else before we move on? I have just a little tiny presentation
Yes,
today.
and then I'm going to steal from a little bit, and we're still going to do your entire thing, but we have that case to go over that got submitted to me that we were supposed to do first, and I forgot, and so we'll do it between the two if that's okay with you.
Yeah, I just want to make one last comment. It's just very, the thing I like about this is that maybe this opens up a little bit of a real need to those listening, that there maybe needs to be a real, genuine study into this topic of VA postcardiotomy, VA ECMO versus postcardiotomy peripheral, because they seem to come up with that central VA cannulation is worse on all fronts.
Mm-hmm.
It's worse 30-day mortality, it's worse on bleeding and blood transfusions, and all the way down the line than peripheral, which is counterintuitive to what we were just saying and what the commentators who you were featuring there were saying. So maybe there's some things here that we don't know, and I think that part of it is very intriguing. That maybe there's something we need to unwrap here that people haven't studied enough.
Yeah, it would be nice. It needs to be a very busy ECMO center to really try to, and that's what, of course, would be ideal, but it's so hard to come by, is if you had, at one center or a couple centers where the same group of surgeons were working, then you're likely to have the technique applied more uniformly. You know what I mean?
Correct. But here's the other thing, and this is probably, I think this is going to be one of the most important things that I've said all week.
Oh, gosh.
Fortunately, I know exactly. Fortunately, we've gotten really good at heart surgery.
Right.
And we don't see postcardiotomy shock
not as much
that often anymore. Yeah. And so to do a study with a high enough N number requires it to be multi-centered. You can never do a single center anything with this. Yeah. And it's going to be very difficult to randomize it as well. There's too many confounding factors. I think you need to look at the bowl of soup that you are confronted with, and based on all available information, make your best clinical judgment as to which is going to be the best for this bowl of soup that's in front of us right now. My only suggestion to anyone who is unable to wean from bypass, especially if they're not in a center that does ECMO frequently, is to stay on pump, slow way down, call a friend, get some information, and develop a plan. At some point in time, once you start to rush.
Yeah, there's no reason to rush off pump.
No. You can stay on pump for a very long time and still have good outcomes. I wouldn't recommend staying on there all night, but I think slow things down and you're going to think through things a lot better. But use your resources, call people that do a lot of ECMO, find out what the best strategy for the patient will be, find out if there's an exit strategy for the patient. Are they a suitable candidate for a durable VAD? Are they a suitable candidate for a transplant? How would you like for us to cannulate this patient for the best outcome? And find out from colleagues what to do. That's something I think that we don't do well in our profession, is call for help outside of our own internal circle.
Yeah.
So that's a very good, interesting. I have a story for you. About 6 or 8 months ago here in Orlando, we're a hub and spoke model where we have many outlying hospitals that send their ECMO referrals to us, and sometimes we go get them, and sometimes they put them on and we go get them. But we got a call about 6 or 8 months ago, and it was a couple hours away hospital. Couldn't come off pump in the OR. They tried coming off pump. The PA pressures were equal to the arterial pressures, exactly the same. Severe left ventricular failure, right ventricular hypertension, and the PAs were exactly the same as the arterial, and they kept trying. They finally called us. By the time the consultation was approved, we got in an air flight, we got packed up, we got over there. It was about 2.5, 3 hours later. The patient had come off pump, and the pressures had normalized. and we actually never did put the patient on
Wow.
ECMO, wound up coming back empty-handed.
Unusual.
So that extra 1.5, 2 hours of pump rest time dramatically changed things
Yeah.
for that patient. So a resting heart.
Now that's air.
That's
Now
done.
that's, as far as I'm concerned, that was air that finally cleared, because that doesn't happen. That's something. So that's one of my, that's like, if I have a patient that's limping around and not looking good, and I suspect there's air down the coronaries, I'll go back on pump. I'll flow as high as I possibly can. I'll drive the perfusion pressure up to 100, 120 as far as a mean is concerned for a little while, and then sort of let it all, wear off. And man, I'll tell you what, I've seen a lot of hearts come back around again because it's basically air down the coronaries, which can happen. I mean, it's, there's air everywhere. Our perfusion mantra is no bubbles, no troubles, but the moral to it is what's a little air among friends. Yeah, you got to remember that.
Yeah, that's it. John, do you have any other thoughts about that?
I'd like to see Joe's case report. I read over it. It's very interesting. I think it'd be nice.
Okay, so we're going to do something a little different today, if I may. And I mean, we'd like to introduce this more. I mean, if people have an interest in this. So I did receive this as an email from a colleague. I have redacted the place that it comes from and don't include his name. But if he'd like to participate or call in, he's certainly welcome to. But I thought it was a very interesting case. So go ahead and throw the slides up. Yeah, mine. The ones that we were supposed to do first. I never do anything in order. I have a real problem with that.
You gotta be
John
flexible.
knows. Look, he's laughing at me over
Yeah.
there. We could see you, John.
Hey, Joe, I have we'll talk later.
Okay. So this was a case sent from one of our colleague viewers. Go ahead to the next. Can you have the clicker? I'll
Yeah.
do it.
There you go.
Okay. So the case history is an 86-year-old female patient diagnosed with CAD, LV aneurysm, atrial fibrillation, and poor EF. There was a history of an anterior septal wall STEMI and status post PCI at mid-LAD OM distal PDA that was done in 2005. She was referred to their hospital 1 month ago for further management. She also presented with acute decompensated heart failure and acute respiratory failure. She was placed on a ventilator. Labs included a hemoglobin of 9, white blood cells 8,000, platelets 272, INR was 1.5, sodium, a little hyponatremic, potassium 3.1, chloride 91. So she was, I would say she was probably diluted. CO2 24, albumin was 2.9, so that was a little low. Creatinine was 2.84, so she was clearly in renal failure at that point in time. Certainly AKI, but probably renal failure. The echocardiogram findings showed a mild LV dilatation with severely impaired LV systolic function. Her EF was 19%. I don't know how you measure 19%. It's either 20 or 25, but 19. Akinetic thinning and dilatation of the LV apical aneurysm, which I'm assuming was paradoxical on top of everything else.
Yeah.
That sounds horrible. And evidence of pulmonary hypertension. Moreover, she also presented with acute kidney injury, and pulmonary edema. The day before surgery, she was treated with continuous renal replacement therapy, so that was wise. Okay, so before we go any further on this case, and look, I don't know the outcome of this case. I really don't. But I'm going to go out on a limb here. If I'm 86 and I show up in this condition, please leave me alone. I don't want you doing anything to me. But you know how it goes. Sometimes you just don't have that choice and you have to do it. But I'm just telling you, if it's me, it's on tape. I want you to just, walk. Don't even walk. No, give me something. I mean, let me feel a little. Give me some good medications, okay? And let me go in peace. So before surgery, the patient's hemodynamic parameters demonstrated instability. They're being unstable. Therefore, inotropic drugs were given. Patient and IV. The hemodynamic parameters included pressure of 119/50, CVP was 11. That's lower than I figured it would be. PAP pressure, pulmonary pressure was 51/27. That's kind of high. Heart rate 92. She was an atrial fib. Her O2 sat was 100%. Baseline gas was 725, 27, 274. So she was pretty metabolically acidotic at that point. Sodium, potassium still low. Calcium was low. Glucose was a little high. Bicarb was 14. Base of negative 14. Wow. H&H was 9 and 33 with a lactate of 9.2. That's a big red flag because she was on CRRT.
So what is it really?
With CRRT, and if you're that acidotic on top of it, think about that. You're masking both the acidosis and the lactate and everything else that's going on here. You've got some big problems here. I don't know what the outcome of this case was, and really, I would love to know. I'm going to have to call and ask. The CPB was performed. They used a Stockard pump, an Inspire 8 oxygenator. The circuit was primed with 600 of ringers, 200 of 20% mannitol, 200 of 25% albumin, 100 of bicarb, 100 mLs of bicarb, 1,000. So they gave some Vanc, heparin, 2 units of RBCs. Flows were 2.4 to 3 liters per meter squared. Used normothermic state around 35. They used cardioplegia with Buckberg. Initial dose of 1,800, repeated 500 every 20 to 30 minutes. They used conventional ultrafiltration with Accusol solution. So I'm assuming they were doing what we would call CVVH, which makes a lot of sense. That's great. I love that. I would have done the exact same thing. We don't use Accusol, we use Duasol, I think is the one we use, but it's the same stuff. There was no urine output. After termination, they used MUF, was performed for 10 minutes. They had volume, I'm assuming she was 932 mLs positive. I'm not sure what that means, the balance volume, unless that's what they removed. The bypass time and aortic cross-clamp time.
Balance volume is after you've done the subtraction of the ultrafiltration and the prime and all of that stuff, right?
Okay.
Yeah.
I don't really know. I'm not positive, but yeah. I'll take your word for it. The operation included coronary grafts, 3, repair of the aneurysm, and ablation for her AFib. And there were moderate doses of inotropes. They were using epi, norepi, and Primacor. Post-operatively, the hemodynamics included that blood pressure, 104/46, CVP of 9, PA pressures were still moderately high, heart rate a little high, still an AF. Results of the blood gases, 7.3, 43, so still metabolically acidotic, but only -5. Lactate was still 7.9, which is very concerning. That almost sounds like a gut infarct to me. During recovery in the ICU, we found the problems with low cardiac output, increased lactate levels. There was unbalance of volume, therefore the CVVH was started immediately. So I don't know if this patient survived or not, but I can tell you right now, that was a salvage operation from minute 1. I think here, we would have been very hard pressed to even have accepted that patient as a surgical candidate.
Yeah.
I can't answer that question, but of course I wasn't there. The questions for us are how best to manage the volume during bypass in patients with edema. Well, I think what you did was exactly right.
That's right.
I measure the albumin. You can measure COP, and please forgive the plug, but if you have our app, you can measure the colloid-oncotic pressure on pump. I think the fact that you used blood made a lot of sense. So, how best to manage volume during CPB is, I think you want the patient, you don't want the patient's tissues to be desiccated, but you want the patient's tissues to definitely not be edematous. So, having a normal to normal high COP, keeping your hemoglobin, your crit elevated, a better level, especially in a critically ill patient, makes a lot of sense to me. Making sure you have enough flow, your DO2 is good, and I think using CVVH with the replacement fluid, not just ultrafiltration, is very good for normalizing the physiology of the patient. In other words, creating a homeostatically neutral environment for that patient. What is the maximum dose of 25% human albumin that we can use during CPB? There is no maximum dose. You cannot overdose somebody on albumin. So you can give as much as you need. Now, of course, it's not going to last forever, and obviously you can no point in just giving nothing but albumin if you don't need it. But there is no theoretical. What's the term that's used for something that's too high of a dose of something? I forgot the term. It's an easy term. Come
Why
on,
are you
help
putting
me
me on
out.
the spot?
When you give, when you have a
Toxicity?
toxic. Yeah, there's no toxicity. Thank you.
Okay.
That was the word I was looking for.
There it is.
Can we use other colloids in patients with AKI? I wouldn't. I don't think there is a replacement colloid that's better than albumin. Albumin is albumin for a reason. It's natural. It's what's synthesized by our own livers. All those other hetastarches and things like that, I think, cause bleeding problems and other issues. So I don't like them. I only like albumin. And, of course, blood as well if needed. And is MUF technique effective in patients with AKI? I'm not a big believer in post-pump MUF. I think that you come off pump and you try to come off pump optimized with your volume and not come off overloaded where you need to then do MUF, and then put the patient on CVVH, process your blood in a cell saver and give it back as concentrated red blood cells. Seems to make more sense to me. I've never really been a big fan of MUF. I think in pediatrics it makes a lot more sense. I don't think that transitions to the adult world, but those are my thoughts. So, John, based on these questions, Tammy, based on these questions, those are my thoughts. What are y'all's thoughts?
You want me to go first, Tammy? Or
Yeah, this is definitely in your wheelhouse, and I know you love all of this, so let's hear it.
So I want to, this is well, I hear what you say, Joe. I think that 80-90% of, I'm not a cardiac surgeon, I would hesitate to say you should have done it, you shouldn't have done it, but probably a large percentage of cardiac surgeons would have tried to convince the family that we're probably not going very far with this. However, maybe this was a VIP, maybe it was a relative of somebody, maybe the patient begged the surgeon to just try anything, and the family did too, and the surgeon said, look, I don't make any promises, but I'll give it my best shot. So maybe that's, I think those things happen. And I'm not sure where you're going with this patient in the long term, because one thing I want to point out to people listening and to ourselves too, because now when you look at one of the first slides and it talks about the left ventricular ejection fraction being only 19%, that's all fine and good. Well, that's terrible, but it's fine and good that you know what it is. But you have to add in the fact that the patient has atrial fibrillation. Without an atrial kick, you lose about 15 to 20% of your effective cardiac output because you don't have complete filling of your ventricles. So anybody who has atrial fibrillation, anybody who has atrial fibrillation is already going to have a decreased cardiac output most of the time, and that's why you have medications and stuff to compensate for that.
Can I make a comment to that?
Yeah.
That's true in cardiac output, not necessarily true if you're measuring ejection fraction. So if you're measuring the EF during a short fill, that's one thing, but if you're measuring it during a longer fill, so I don't know how they did that. So it's true on cardiac output, but it sounded to me, based on the akinesis, the thinning, the aneurysm, which was probably post-infarction in nature, I agree with you. The atrial fib is an issue for cardiac output, but I think in this case, their ejection fraction probably wasn't even 19%.
Right.
That was either very generous, because it's an odd number anyway, but my suspicion is this patient had a really bad bad ejection fraction.
Right. Well, that's just sort of something to keep in mind for people when they see a patient with AFib in general. But a bigger picture than that is what you just said about the LV aneurysm. And so they did an LV aneurysm repair. What does that mean? Does that mean they resected? And by the way, they give the measurement there, 4.9 centimeters by 4.9 centimeters, which, by the way, is just under 2 inches wide by 2 inches long, right? Because it's 2.54 centimeters per inch, and this was nearly 5 by 5. So I think that's probably a pretty sizable aneurysm for a little lady, 86 years old, in her left ventricle. So if you're going to resect out that amount of myocardium, how much of a left ventricular ventricle do you have left as far as
what's the volume, right? Your volume of that ventricle is going to be very, very low.
Right.
Right.
Yeah.
So you combine now that you've done the surgery and you're 72 hours in, you've decreased the size of left ventricle. You're still in atrial fibrillation because I'm pretty sure this lady probably had chronic atrial fibrillation. It's probably not something that's happened 2 days before she walked in the hospital. Could be. They don't specify. But she's probably stuck in atrial fibrillation. They tried treating that with the ablation. I'm not sure what the success was. But now you still have the problems of pulmonary hypertension and pulmonary edema. So Joe and Tammy, I want to ask you this. If you were going to do this patient, would you not have tried to spend a week or 10 days and tune this patient up really more tightly with maybe 3 or 4 episodes or maybe a week of CRRT and bring her hematocrit up, her electrolytes more in line because the sodium's low, the potassium's low. You want to shift volume back out of these tissues like the lungs, which it says there she has pulmonary edema, and fine-tune this patient a little bit, or you think they just couldn't wait and had to take her to surgery right away because of the high lactates was another big problem?
I think the latter is correct.
Right.
I don't think this patient was...
they probably wouldn't have survived a week.
No, I don't think
Not
they were
with
going...
the lactate climbing like that.
Yeah.
But I agree. If you didn't have such a high lactate, you just let's just say it's mildly elevated, tuning them up would give you a better chance. But
yeah, it doesn't sound like this patient was tunable. I think this patient was either going to be fixable with going on, just full mechanical circulatory support of the pump. I think their thoughts, and of course I'm not them, and they're not on the phone.
We don't know
this
the
is
situation
right.
completely.
I'm not there, but I'm going to hypothesize, if I may, that they thought, okay, let's go ahead and put her on pump. Let's get her washed out. Maybe we can get, good perfusion to all of her tissues, get everything turned off while we're on pump, get the heart revascularized, get the aneurysm resected, maybe, treat her AFib, and then try to come off. But that's the leap that they had to make to say that this condition, especially this high lactate, is reversible. But my suspicion is
it wasn't,
that it
was
wasn't. Yeah, because I think that the gut probably had sustained an actual infarct versus just being ischemic. But it sounds like the mesenteric artery probably went down, and for a lactate to be 9 on CVVH is really like having a lactate of 18, depending on how much replacement fluid they were using.
Yeah.
And so you can look this up to be more specific, but when you have lactates in the double digits for more than 42 to 78 hours, and let's assume you said it was 18 and maybe it was 12, and that alone carries a mortality rate in the high 80%, generally anyway. But the other thing is, I'll let Tammy jump in, is I want to talk about on bypass. They asked a question about the using the osmotics, and albumin. Definitely, they did a very good thing there. But what they might have could have done, because the albumin was 2.9, it's not even normal. 3.4 to 5.4 would be normal. So you could have run an albumin and at least got your albumin all the way to high normal. Got it all the way up to 5.4 is what I would have tried to do. And even if you went a little higher, like you said, Joe, there's no toxicity, and tried to move this fluid back intravascularly. But here's a problem: there was no urine output on bypass. So they did use mannitol, which, by the way,
is a problem.
Mannitol is not a diuretic.
Right.
Mannitol is not a diuretic. It is only a fluid shifter. And if your kidneys are working, now it becomes added to your urine output. So when they were on pump and didn't see any urine output, I'm a little curious why maybe they didn't try some type of direct Lasix or Bumex or something. What are your thoughts about that?
Yeah, it sounds to me like she was, I mean, they say AKI, but I think she was in just renal failure. They were committed, I think, to dialyzing her. I wouldn't have seen, you can give the loop diuretics, give Lasix if you want to, but that carries its own risk. It's neurotoxic. Giving the mannitol, I don't really have a problem with them giving it. It is known as a osmotic diuretic.
Right.
To your point, it operates on a different wavelength by pulling fluid. So if they were using it to just pull fluid in and they were doing aggressive ultrafiltration on top of it, I don't really have an issue with it at all. I used to love to give mannitol. And I know we've largely abandoned it, but we used it when we took the cross clamp off as a scavenger for oxygen-free radicals at the time. We really believed that it worked. I still do believe it works, but it's kind of like DDAVP. I really believe DDAVP works. And does it or doesn't it? I don't really know. Some people say it doesn't. Some people say it does. I think it really just depends on what you believe in. And if you give it and it works, then it worked, regardless of what other things you may have done that may have actually been what worked, because that's how we operate. That's how we work. We're all of us, use the best information we have, but medicine is an art form. It's not a complete science because humans are so difficult to predict. They're predictable and unpredictable in their nature all at the same time.
Really the only comment I have, and it's really more of a discussion question for you, John, since renals are your favorite. I was always under the impression if you have someone with a kidney injury that although you want to, you don't necessarily need to rule out giving mannitol, I thought you were supposed to limit it.
I think I think the concern, and I've heard that same thing, but I believe the concern of that is you don't want to put the patient in heart failure. So if you're giving medications to pull volume in,
and then you can't get rid of it.
You can't get rid of it.
But because they were ultrafiltrating, it was okay in this situation.
Yes. And
John?
that's the thing that I try to tell people. If you're on pump, it's easy because we have a reservoir.
Right.
But if you're in the ICU and you have a patient and you're doing correction of a very low oncotic state, you better be pulling fluid off with the CRRT machine pretty quickly, because every gram of albumin brings 18 mLs of fluid back from the extravascular space intravascularly. So that's about the average, 1 gram per 18 cc's. So you give 100 grams, you're going to get 1,800 mLs.
John, any thoughts on my just comment?
Well, I was going to say for people listening too, and for all of us too, mannitol in the absence of any kidney function is nothing really more than an oxygen-free radical scavenger and a volume challenge. You're giving the patient a volume challenge in the absence of decent urine output. And I'm not saying it was wrong. In fact, they needed to bring fluid off this patient. Yeah. They had the ability to remove it. And also, I do love the fact that mannitol is an oxygen-free radical scavenger. And I think there's a lot of evidence about, and everywhere I go, Joe, I'm surprised you're saying you're not seeing some, everywhere I go, that people give mannitol when the cross clamp comes off. So I think it's still very prevalent.
I give mannitol.
You do, but I mean, a lot of people don't. Here, you work with people that don't do that. I mean, I've seen it sort of go by the wayside.
What would be the reason?
I don't know, John. You got to ask them. I'll give you their names and numbers.
Yeah, I don't know either. Just should tell them. You should tell them something that you should tell them. You thought you were wrong once, but you were mistaken. That's
yeah, that's very good point.
That's what they're doing by not giving mannitol.
I agree with you 100% on that. Okay, so did you have more on the ECMO cannulation?
Yeah, but it was really...
That I've cut you short on?
But I really want to get to John's knowledge nuggets before, because really this is just a review. I was just going to show some images we've shown in the past of...
well, let's do them. Let's stay with the ECMO since we're doing ECMO.
Okay, let's really brief. It's only a couple slides.
I'm just glad they didn't put this patient on ECMO and take him to the unit. Okay, so whatever you guys did out there, and please let me know how that patient did, but please. because I'll tell you what, if you send me a picture of her working in her garden, I'm going to be very upset at myself today.
But amazed.
Amazed, yes, I'd be very happy, but I'd be amazed.
Okay, so since we were just talking about ECMO cannulation in our journal club, I thought we'd just review a few things, which I think we brought up many times on just various ways to cannulate. I think you like to call them exotic.
Exotic cannulations. I love exotic cannulations.
Okay, so I found this article that has a great graphic that I think I've seen before, so I wanted to just go ahead and give credit to this was an article that was published in the European Journal of Heart Failure in May 2017 by Sorkin, I'm hoping that's right, and colleagues, and it's choosing the appropriate configuration and cannulation strategies for ECMO, and they go into some things we're not going to look at, but the potential dynamic process of organ support and importance of hybrid modes. But they have an excellent point in their conclusion I do want to go ahead and bring out, but mostly I'm just borrowing their diagram. Okay, so I think we've seen something like this, if not this exact one, because it's really great how it's all summarized here. But you can see, of course, all the different ways that you can solve some problems that you have on ECMO. So starting with the, the double venous drainage and one arterial return.
And what has John taught us about the dash?
It is where the oxygenator is.
Represents, John, that came from John Ingram. The dash is what represents
that was
the
the original knowledge nugget.
That's right.
The original knowledge nugget. Because I'm very careful about that now. I don't know why I didn't know that.
Mm-hmm.
Yeah, anyway. And you can see here that the first one, you've got A and B you could really kind of compare. They're just various ways where you're going to get your second venous return. One's the IJ and one's a femoral, or both femorals. And then we've got the VVA with our dual lumen, right? I think that's what that is.
It is.
Okay.
You're pulling from both.
Yep. And then we've got our VAV, where we've got two returns, right? One venous and one in the IJ, and then one in the femoral artery.
That's what happened with the kid down in that other hospital.
Yeah.
Where they had the patient. What is my message about what ECMO never to use for a normal to hyperdynamic heart with pure pulmonary failure? You never use VA ECMO with peripheral cannulation.
Right, you can't.
And they had classic Harlequin differential hypoxemia, whatever you want to call it, and they converted him from VA, fem, to this very thing,
to D.
VAV.
Yeah, exactly. Exactly.
And he improved dramatically.
And, I mean, I think most people listening probably understand, but the reason why is his heart was working against what was coming towards him. And so,
he was 29 years old, and he had a hyperdynamic heart.
Mm-hmm. Okay, and then you can see down on the lower level there, on the second row, if you will, we've got VAV just in another configuration. And then we've got VVAV, VVAV again with another configuration. And then this one that I've actually never seen, VVVA. Have you ever done that?
I have never done VVVA.
What about you, John? VVVA. Venous.
That would be very strange, because if you didn't have enough drainage with one cannula, you would certainly have enough drainage with two cannulas. But apparently in this drawing, somebody felt like you needed 3 cannulas to have enough venous drainage. So maybe this is something somebody's seen in a pediatric or something along the lines of very tiny cannulas. But I can't imagine this scenario in an adult.
Yeah.
I've never seen that.
Seems like a lot of venous cannulas to keep up with, too.
It does. And I would say that probably the problem wasn't a lack of cannulas. It was maybe they were having flow problems because there was a lack of volume in the
right.
Yes.
It wasn't a lack of drainage, probably. Maybe a little bit, but it was probably a combination of volume as well.
Yes.
Yeah. Okay. So here.
You know what they say? If one cannula doesn't work, add another.
Is that what they say?
No, but I just thought I'd say that.
Okay, and I have no disclosures or affiliations. I borrowed all of these diagrams because they're so perfect from the manufacturer's websites. But, dual lumen is becoming quite common, and so I thought it'd be worth just a minute or two to go ahead and just look at the 3 that I know of. Joe, do you know of any more?
I do not.
Okay.
These are the only 3 I'm aware of.
So we've got the Tandem Life, which they actually show their, it's the Protect Duo, and they show their circuit as well. But, you know, it's IJ access, and you can see how the cannula has to then be sort of guided up into the pulmonary artery there. And then we've got the Avalon in the center by Gettig and the Crescent by MC3. Now those are very similar in that their placement, I think, is almost identical type of technique, if I'm correct. I've never actually used a Crescent, but you have, haven't you?
Yes.
Yes.
And John has too.
Yeah.
It's a, you know, some people really like it, some don't.
Mm-hmm. But it's very similar to the Avalon, am I correct?
Very similar.
And how it has to, it's positional and how it's pointed and all of that sort of thing.
Yes, it has bicaval drainage with right atrial return, and it does need to be rotated properly to be pointing towards the tricuspid. All of those, the same nuances associated with the Avalon exist with the Crescent.
Right, and you can see in the Avalon and in the Crescent, they also show a pretty good demonstration or illustration of the heart, of just showing where the jet needs to be pointed there. Okay, and then let's just get to the conclusion from this article where I had borrowed the original illustration of all the different kinds of exotic VA ECMO cannulation. I wanted to just read something that I thought was really important. Cannulation will also characterize the kind of ECMO configuration you have. ECMO configurations should not be seen as static or unchangeable. Changes in the patient's condition, disease progression, or development of organ failure should trigger a reappraisal of cannulation strategy and circuit configuration due to suboptimal ECMO performance or related to new clinical hemodynamic or metabolic conditions. So that's really what I wanted to get to, because we've had some experience with that, and that's really it. See, it was real short. You can take down the slides. We've had some experience even with that very recently of, you know, our cannula was placed perfectly.
Yes.
Our patient lost a lot of weight, and then what happened to our cannula placement?
The cannula actually, the position in the skin was the same, but the cannula popped out of the IVC. Now, granted, he also had an acute angle on his IVC, which was odd, but he lost so much weight, but also volume. His whole anatomy changed enough that the tip of the Avalon popped out and flipped into his RV.
And I think that leads us right into, you can start out on VV, let's say, and then start having, you know, some heart failure problems, and you might need to convert to one of these exotic things.
Absolutely. Absolutely.
And so it's important to remember that the solution at the beginning is not necessarily going to be the solution through the entire therapy.
Well, it's like that algorithm that I have, which we need to add to the app, by the way, which reminds me of that. We can't forget that. We need to get that done. But the algorithm of Ecmo Selection, if you have to consider, is your heart failure secondary to hypoxemia only? And if it is, your instincts are, they're in heart failure, we need VA ECMO for circulatory support, but really they just need oxygen.
Right.
VV ECMO is really the right choice. But if you do VV ECMO and you made that decision based on that algorithm, and they're still not doing well and do need ventricular support or circulatory support, it's very easy to Y that around and do what would be V-VA or AV, as depending on the case may be.
Yep. John, what's your experience? Have you done any of these types of things where you've had to convert from VV to say VA or VA to VV as the patient's hemodynamics changed, organ failures?
I wish I had $1 for every time we have. It's something we do all the time. But I wanted to make a comment on your very last slide there, where you were reading a couple sentences there. I don't know if you could put it back up, but you said in there something about suboptimal
ECMO performance.
ECMO performance, so how do we know how do we know we're having suboptimal ECMO performance for people who maybe don't do too much ECMO?
There we
Yeah,
go.
so it says there, somewhere in the middle, you're reading there, changes in the patient condition.
You can move the mouse in here.
Oh,
I'll
yeah,
do it.
sorry. Here, let me do that.
So suboptimal ECMO performance or related to new clinical hemodynamic or metabolic
Yeah.
conditions. So how does somebody who's doing ECMO for at a new center or maybe not so experienced center, how do you know you're doing suboptimal ECMO performance? You need to be watching your venous saturations, you need to be watching your arterial saturations, and something we were just talking about in the last segment, you need to be watching your lactates. If your lactate levels are rising, regardless of whether you have VV, ECMO, or any of those alphabet combinations you had up there, Tammy, if your lactates are rising, you need to address it. You're doing something wrong or suboptimal. If your lactates are going down, that's a very good indication you're doing things correctly. But in addition to that, if your
or the
lactates
patient,
aren't,
maybe not correct or incorrect, correctly or incorrectly, but your therapeutic treatment option or modality is maybe effective or being ineffective, because
right.
it could be your lactate could be rising for a reason other than suboptimal ECMO performance.
Other than suboptimal.
Other than, right.
Well, I think he's trying to give you some clues, though.
Yes, but I mean, I agree with that. I agree with you. I just wanted to add that sometimes it's not necessarily correct or incorrect. It just may be effective or ineffective.
Right.
Well,
I'm just
right
making a nicer way of saying the same thing.
Right. And
yeah,
well,
right there is suboptimal. Is suboptimal. Yeah. So that's a good word to use. But there are things that can cause lactates to go up or down. In fact, like you said, CRT is masking your lactate. But if you're going to take responsibility, so to speak, for the patient's pulmonary function by VV ECMO or cardiac and pulmonary function via VA ECMO, if you're going to start taking that onus on you as the ECMO program, then you need to start, try to own that as much as you can. And if the lactates are going in the wrong direction, you owe it to the patient, you owe it to yourself to say, are we doing everything we possibly could be doing right? Because we've now shifted the lung and cardiac responsibilities have sort of now been shifted over to us, and so we need to be very acutely aware of it.
Agreed.
I'm surprised how many.
Agree with you 100%. I couldn't agree with you more.
I'm surprised that we haven't made that just really normal standard of care that when we're on ECMO, tracking lactate.
What's the first question I always ask? I mean, we should.
No, I know. But
everyone should.
Not everyone does, though.
But they should.
And sometimes we get on and we don't even have a baseline, so we don't even know where we're starting from. That should be one of the very initial labs that we're doing.
Yes,
don't you think?
And yes, I agree, and I do think it is. And I think lactate is important. I think all of this is important, but I also think that we're so good at correcting the labs that if you don't find and correct the source of the derangement, whatever that may be, an ischemic leg, ischemic gut. I mean, one of the things that drives me absolutely crazy is going into a patient who is on VA ECMO only to find they're on max doses of epi, norepi, neo, and let's just throw some dopamine on there as well, some dobutamine on there as well. The whole point of being on ECMO is to turn that off. Now, clearly some patients have they have vascular, paralysis, what they call vasoplegia syndrome or something like that, for whatever the reason may be. But, I think if you do ECMO, and a lot of people disagree with me on this, and I respect the differences of opinions, but I believe any patient who is on ECMO, even if they're making urine, should be on a zero balance CVVH to maintain fluid balance and to maintain normal homeostasis, and not sit and wait for the urine output to continue to diminish, or to treat low urine output with mega doses of Lasix and whip the kidneys into working when they're already in a compromised condition. They may be making urine right now, but I just think that if patients on ECMO, they should be on CRRT at the same exact time. And I think we need to be very careful about recognizing that CVVH and ECMO mask a lot of problems. And you have to be looking for them before you can really get the therapy to do anything more than be supportive, which is all it is. All it does is buys you time to fix the underlying condition. And if conditions, as the case may be, and to try to minimize creating more problems. But, you know, ECMO is not without its own morbidities, you know, whether it be coagulation derangements, both being coagulopathic and bleeding, or hyper. You can have incidents occur, air entrapment, vascular trauma. You can have trauma putting the thing in, limb ischemia. I mean, there's just a whole variety of shock liver. I mean, I've seen all kinds of things happen because of ECMO, as well as ECMO save a lot of people. So you just really have to, the central message for me is, if you need to use ECMO, if you're going to use it, you don't do it frequently, you have to be very selective with its use, and you need to learn as much as you can before you're confronted with that case, and utilize resources around you by reaching out to people who actually do it a lot, both from the medical side, the perfusion side, and the nursing side, to make sure that your patient is given the best opportunity for success. That's my central message.
And let me just conclude by saying, for anybody wondering, scratching their head, circle back about the lactate, you really should be running lactates once or twice every shift, and then at least once every 12 to 24 hours after the third or fourth day, once you've seen it level off and come down, so you can get a good sense as to whether or not you're actually benefiting the patient or not, and then also if they have other problems going on that may not be related to that.
Agree.
Absolutely agree.
Okay.
Okay. Are we ready for a knowledge nugget? Because I look for that gold nugget up at the top. I look for it every day. And I have my notepad right here to write them down.
All right. You're going to get a few today, I think.
Okay.
Sounds good. And you're on the oxygen dissociation curve, right? Oxyhemoglobin dissociation curve?
Yep.
Dude, I'm glad, because I get that mixed up all the time. Shifted right, shifted left, which way is it shifted? I just say
be real cleared up
it's
today,
shifted.
We're
It's going to be clear. Okay, good.
Good.
I hope so.
All right.
Running the intro? Okay. Okay.
All right. Very good. So let's see, can we key up the slides, I guess? All right, guys. So today is March 10th, 2021. This is episode number 4. Can you believe it, guys? We're already up to episode number 4 of John Ingram's Knowledge Nuggets. Of course, I am your host. I don't have any disclosures on any of these topics today or any other day. And so our motto here at Knowledge Nuggets is just spend a little bit of time and expand your mind. Quick and clean and something you can use. This week's topic, like Joe said, oxygen dissociation curve. Something we've all learned about, but something we all think to ourselves, do I really have a firm grasp of this? This is also known as oxygen hemoglobin dissociation curve. 2 words, 2 names for the same exact thing. But this one's kind of, even though it's longer and people shorten it to oxygen dissociation curve, this is actually makes more sense because it's the hemoglobin oxygen ability to bind together and work together is really what this curve tells us. And so that's why this is a little bit better of a name, a little longer to say though. So our format is we're going to do a different topic each week, and we're going to give you something that you can take home, a little nugget of information or two that helps you be a better clinician tomorrow. And when you see a slide with a gold shining gold nugget there up in the upper right hand corner, you'll know that this is a take-home slide. And you can take a screenshot, take it to work tomorrow, and be a better clinician tomorrow, hopefully. Of course, our segment, if anybody's ever not watched before, it's just 12 to 15 minutes, highly impactful. Then we do a surprise, 2 to 3 minutes gem of the week, a little nugget. You don't know what that's going to be. We always need that for a surprise, followed by panel discussions and questions. And if any of you are watching this live or in the future or any previous episodes, email me, john.ingram@perfweb.us, and I will always reply to any questions or comments that you guys might have. Okay, so what is the oxygen dissociation curve? So here's a take-home slide. We're going to define it. What is the definition of oxygen dissociation curve? Well, it plots the proportion of oxygen-saturated hemoglobin on the y-axis, the vertical axis, against oxygen tension, the PO2, on the x-axis, or the horizontal axis. The oxygen dissociation curve relates oxygen saturation and partial pressure of oxygen in the blood. Gives us a relationship between those two, which means it gives us a measure of the hemoglobin's affinity for oxygen. Affinity meaning its attraction to, accept, and hold on to oxygen. And it tells us how readily hemoglobin is going to acquire oxygen in the lungs and how easily or readily it's willing to release that oxygen into the tissue. So this is why it's important. So just a little bit about the hemoglobin molecule real quick. Hemoglobin is a protein, and the red blood cells, there's over 260 million hemoglobin proteins in each red cell, and each hemoglobin molecule is made up of 4 chains, 4 polypeptide chains. Each one has a polypeptide chain and a heme group, and that heme group contains iron. It's at the iron site where the oxygen binds to. So there's 2 alpha polypeptide chains there shown in blue, and 2 beta polypeptide chains shown there in red. That's not terribly important. They all do the same thing for the purposes of today's discussion. So hemoglobin, here's some fun facts that have to do with today's discussion. Well, first of all, hemoglobin is the primary vehicle, as you guys know, for transporting oxygen in the blood. But each hemoglobin has the capacity to carry up to 4 oxygen molecules as a maximum. The binding of the first oxygen molecule causes the hemoglobin protein itself to change shape. It's that change in shape that increases its ability to further bind to the other 3 oxygen molecules. One of the themes that I'm going to talk about today, guys, is that the amazing hemoglobin protein continually changes its shape due to influences from all sorts of outside influences, including when an oxygen molecule attaches, it actually changes its shape. This change of shape is what changes its ability to function and its affinity for oxygen and carbon dioxide. So we're going to continue to talk about the hemoglobin molecule changing shape. So in a high carbon dioxide and acidotic environments, such as in the tissues where metabolic processes are going on, the low pH, the acidosis, causes a change in the shape of hemoglobin protein. This change in shape increases its ability then to bind to carbon dioxide and decreases its binding force to oxygen. This is most desirable in the tissue. So high CO2 and acidotic environments, as soon as hemoglobin approaches the tissues, is influenced by this. It changes its shape. This changes its affinity to release oxygen and increase affinity for binding up to carbon dioxide in that environment. So hypoxic environments, low oxygen environments, cause hemoglobin to decrease its ability to bind oxygen and readily releases oxygen into the tissues. So this is another influencer. So again, as the first oxygen molecule is released, the first carbon dioxide molecule attaches. Think about a revolving door. You ever been to a large, shopping center where they have the revolving door? People can go in at the same time that people are coming out. So the hemoglobin molecule can function the same way. An oxygen molecule can be being released as the first carbon dioxide molecule can be becoming attached. And this then causes another change in shape of the hemoglobin molecule. This change in shape further causes release of more oxygen and increases the ability to bind the carbon dioxide. So this is, what we all know as gas exchange. And by the way, the carbon dioxide molecules do not bind to the same sites that the oxygen molecules bind to. The carbon dioxide binds to different peripheral sites on the hemoglobin molecule, not the same oxygen binding sites. The oxygen bound to the hemoglobin is released and is absorbed into the tissues, and the carbon dioxide in the tissues becomes bound to hemoglobin. So that's a quick one about. So now, in the lungs, the reverse of this process takes place. Of course, with the release of the first carbon dioxide molecule, the shape of hemoglobin changes back, and it makes it easier for the 3 other carbon dioxide molecules to be released, and easier for the attachment of oxygen. So hemoglobin is remarkably flexible. In any environment that it's exposed to, it immediately changes shape. That change in shape alters its affinity and its adaptability to either release or attach the appropriate oxygen or carbon dioxide molecules. So it's amazing. So let's talk about the oxyhemoglobin dissociation curve. So you see on the left axis, the y-axis, that's your oxygen saturation of hemoglobin, how much hemoglobin is saturated from 0 to 100%. And along the x-axis, our partial pressure of oxygen, which in normal physiology would range from 0 to close to 100%. Somebody that is, not in a medical condition where they're requiring oxygen. And you can see there that you can shift this curve to the left, or you can shift it to the right. And if it shifts to the left, this is an increased affinity for oxygen. Hemoglobin is going to have a higher attraction and binding rate to oxygen. And on the right shift, it's going to have a lesser affinity for oxygen and a less ability to hold on to the oxygen. So just looking at this, so you can get an idea, at a partial pressure of PO2 of 40 would give you an oxygen saturation of 70%. That would be relatively normal. So let's say we have a left shift in the hemoglobin oxygen dissociation curve, and you would see that now you have an increased affinity for oxygen, so you would only require a PO2 of 30 to get that same 70% saturation. That's because the oxygen, the hemoglobin, has a higher affinity for accepting the oxygen. You don't need as high as a partial pressure of O2 to achieve the same saturation. So now what happens if so these are the things that are going to cause a left shift and a higher affinity for oxygen. A lower carbon dioxide level, a lower hydrogen ion concentration, which means alkalinity, high pH, a lower 2,3 DPG level, which we're going to talk about, and lower temperatures. These 4 things, and it's going to be easy to remember this by the end of this talk, these 4 things are going to cause hemoglobin to have a higher attraction or a higher affinity for oxygen, a left shift. So let's summarize the left shift. And here's a take-home slide for you guys to figure out, well, what does it mean when it shifts to the left? This leftward shift indicates that hemoglobin has an increased affinity for oxygen, so that the hemoglobin binds oxygen more easily and releases it more reluctantly. So if it's going to bind to it more easily, it's not going to let go of it as easily either, right? It attracts it higher and holds on to it stronger. Basically, it's the same force. The left shift of the curve is a sign of hemoglobin's increased affinity for oxygen. This is what hemoglobin does when it passes through the lungs. High increased affinity for oxygen, which is very fortunate and makes sense for its function as it passes through the lungs. Now let's look at a right shift of the curve, which means hemoglobin would have a decreased affinity for oxygen. Okay? So therefore, instead of having a PO2 of 40 with a 70% saturation, you would require a PO2 of 70 to get that same 70% saturation, because hemoglobin is being resistant to accepting the oxygen. It's less, it has a lower affinity. So therefore you require a higher PO2. So this is a right shift. So now it is directly the opposite of what is going to cause a right shift. Higher carbon dioxide environments, higher hydrogen ion concentrations, meaning acidosis or lower pH, higher productions of 2,3-DPG, and higher temperatures. And we're going to explain all this very easily in the next phase here, so you can keep this. And now, take-home slide, what is a rightward shift? It indicates that the hemoglobin has a decreased affinity for oxygen. It is more difficult for the hemoglobin to bind to oxygen, but it is easier for the hemoglobin to release the oxygen, which is what occurs in the tissues. The effect of this rightward shift increases the oxygen in the tissues when it is most needed, such as during exercise or shock states and low oxygen states and so on. So now, this is how we're going to remember this. In order to remember this, there's a mnemonic. Is that how you say that word, mnemonic?
Mm-hmm.
So there's a mnemonic that if you want to remember what causes it to shift to the right, it's always the opposite of that would cause it to shift to the left. So the mnemonic that's used is called cadet face right, like we would say in the military. Cadet face right, okay? This stands for an increased, the CADET, the cadet stands for CO2, acid, 2,3-DPG, exercise, and temperature. Yeah, Joe, go ahead.
Yeah, it's cadet right face.
Yeah, except in this case,
face
okay,
right.
you could use that.
Yeah,
you could do it that way.
Well, I just wanted to let you know.
Well, wherever I read this, apparently maybe it was a British style or something. Yeah, but you're right. It's right face. That's good. I like that. So remember, this is increasing these things. They're all going up. In an environment of a high increased CO2 level, in an environment of increased hydrogen ion concentration or acid environments, increased production of 2,3-DPG, which we're going to talk about, and when you exercise and in higher temperatures. Well, by the way, in the muscles, when you're exercising, they generate heat, right? So going on here for a second, I don't want to get too off on that, but factors that move the curve to the right are those physiological states where tissues need more oxygen, right? Tissues are going to have a higher carbon dioxide level. They're going to be more acidotic because that's when metabolism is taking place. The 2,3-DPG I'm going to talk about. The tissues, like in the muscles, and you're exercising, they're high metabolic, and they're increasing their temperature because they generate heat as they exercise, especially in the muscles. So everything that requires oxygen is where the curve gets shifted to the right, and this transforms hemoglobin to release that oxygen, ideally in those settings, and also absorb more carbon dioxide. So for example, during exercise, muscles have a higher metabolic rate, need more oxygen, produce more carbon dioxide and lactic acid, and the temperature rises because, as you know, muscles generate heat. So all these things fit hand in hand. So let's talk about each one of those. pH. An increase in hydrogen ion concentration or a lower pH shifts the curve to the right, as I just said. This occurs because at greater hydrogen ion concentrations, there are surrounding amino acids that attack the hemoglobin or influence the hemoglobin and fix it in a state of lower affinity. So I'm talking about why does a decreased pH shift the curve to the right? Because there are amino acids in the area, in the red cell, that affect the hemoglobin and fix it into a state of lower affinity, so it releases its oxygen easier. This also, by the way, is known as the Bohr effect you might have learned in school, which means in higher acidic environments, hemoglobin decreases its affinity for oxygen, known as the Bohr effect. So now, why does carbon dioxide affect this? Carbon dioxide affects the curve in two ways. First, increased carbon dioxide levels cause carbamino compounds to bind to hemoglobin. Anything that influences hemoglobin alters hemoglobin's ability to bind to oxygen. So these carbamino compounds, which are stimulated by high increased carbon dioxide levels, affect hemoglobin, and they affect it in a way to bind to oxygen, alter its ability to bind to oxygen. Secondly, high carbon dioxide levels increase acidity, as you know, which shifts the curve to the right, as I just discussed in the hydrogen ion slide, in the pH one, okay? Carbon dioxide, so in low carbon dioxide environments, that results in alkalinity, such as in the lungs, and shift the curve to the left, thus providing stronger binding conditions for hemoglobin to oxygen to accept oxygen molecules. In high carbon dioxide environments, results in acidity, such as in the tissues where cellular respiration is occurring, and therefore it requires oxygen, produces carbon dioxide, causes the shift to the right, thus causing weak binding conditions for oxygen to hemoglobin and causing a release of the oxygen from the hemoglobin. So let's look at 2,3-DPG, which, by the way, has been its name for decades and decades, and now they decided to change its name to 2,3-BPG, which is now 2,3-biphosphoglycerate. It was 2,3-diphosphoglycerate, which, by the way, means the exact same thing. So I'm not sure why, excuse me, why they changed the name, but they feel the need to change it. So we technically should be calling it 2,3-BPG. And this is an organophosphate that is inside the red blood cells. It's formed inside the red blood cells during the glycolysis process. So now they believe that the production levels of this 2,3-BPG is likely an adaptive mechanism because it just so happens that 2,3-BPG production increases whenever the red cell is in a low oxygen state, such as hypoxemia, chronic lung disease, anemia, and congestive heart failure. So what's interesting is that when the red blood cell notices it's in a low oxygen state, it suddenly produces more 2,3-BPG, which, by the way, affects the hemoglobin to release oxygen more readily. So it's very likely an adaptive mechanism.
I'm not changing how I say 2,3-DPG.
I was thinking it messes up our mnemonic.
It does.
Right.
And
Exactly.
I'm not changing.
I'm not changing it either. So we're going back to 2,3-DPG, Joe. There you go. So when you increase this 2,3-DPG, this DPG binds preferentially to the hemoglobin, meaning it doesn't bind to it on the oxygen receiving sites. It binds to it in a preferential form, and it diminishes its ability to bind to oxygen. It affects the hemoglobin. As I said, all of these many different things affect hemoglobin's ability and its affinity. So it's very interesting. High levels of 2,3-DPG shift the curve to the right because causing hemoglobin to release oxygen into the tissues more readily. So therefore, it's very necessary and helpful. Conversely, the absence of 2,3-DPG increases hemoglobin's affinity for oxygen.
Which is a big problem with allogeneic blood transfusions because they are essentially 2,3-DPG depleted.
Well, that would mean that, it would be not want to release the hemoglobin very well then, right?
Yes, and there is that argument that massive transfusions can be an oxygen sink.
Yeah.
So that the longer especially older blood, and that you want to try to use newer blood as possible, and why pediatrics are so, they're very strict about that. They won't use, I think, more than maybe 5-day-old blood.
Yeah, it's like under a week, I think.
Yeah, it's very, very strict with that, and that's one of the reasons.
Yeah, it's very interesting. Now, what about exercise? Because that's the E in our mnemonic, right? Exercising muscle cells release hydrogen ion, produce carbon dioxide and lactic acid into the surrounding blood capillaries. Working muscles create a much higher temperature than in inactive tissues. So blood entering the exercising muscles is acutely exposed to this environment. More specifically, the hemoglobin is exposed to this acute environment. All of these things, the increased hydrogen ion, carbon dioxide, acidic level, heat, and temperature, all cause a rapid decrease in hemoglobin to oxygen affinity, which is very productive and fortunate because hemoglobin will release all of that oxygen that it's carrying into the tissues where it's needed. So then, of course, increased temperature. Now, what does increased temperature do? The muscles are exercising. The friction and the work of the muscles increases temperature, right? Well, this temperature itself denatures or weakens the bond between iron in the hemoglobin and the oxygen. Remember, the hemoglobin is bound to the iron receptor site. The weakening of this bond decreases hemoglobin's ability to bind oxygen. So increase in temperature therefore shifts the curve to the right due to the increasing hemoglobin's affinity for oxygen. So all of our mnemonic work together to make a very synergistic effect to where when hemoglobin approaches the tissues, all of those 5 factors are causing hemoglobin to be very low affinity, release all its oxygen, and the reverse is true, to pick up carbon dioxide on its way out of the tissues and back to the lungs. So now we're looking at the complete picture here. So as you can see, the reason this is easy to remember is if you look on the left side, where you want an increased affinity for oxygen, as in the lungs, you don't have high carbon dioxide levels. In fact, you have very, very low carbon dioxide levels. You're not acidotic in your lungs. The red cells are in a high oxygen environment, so they're not producing 2,3-DPG, and the temperature is normal. And the hemoglobin picks up tons of oxygen and lets go of the carbon dioxide. Now it arrives in the tissue, and it shifts to the right, where there is a high level of carbon dioxide. There is acidosis because of the hydrogen ion being picked up. The red cells are producing 2,3-DPG because it's a low oxygen state, and the temperature is higher because metabolic processes are going on. So instantly the hemoglobin shifts to the right and releases the oxygen and picks up the carbon dioxide. So doesn't this make perfect sense now that you look at it?
Yes, it really does. And
you know what the key is remembering what's direction. Not the direction. The direction, well, I guess you could remember that, is if you can remember what is on which axis, because then the direction makes perfect sense.
Yes, absolutely. Right? Yes. Yes. Well, I usually just say shifts the oxyhemoglobin dissociation curve. I keep myself out of trouble by not committing to a direction. I just say, I know that it's going to shift it one way or the other and decrease its ability to release or ability to pick up.
And John, if I may interrupt you for a second, this slide is so great because it's very summarized, and you can see a real easy way to remember this. So it's an inverse relationship of all the factors that we're looking at. As long as they're all going down, our oxygen affinity for oxygen saturation is going to go up. And the reverse is true. If we wanted to talk about increasing everything, will decrease.
Which brings up a question for me, but I don't want to ask until I know John is ready for questions. So I've got a tough one for you.
I want to point out to Dave and your engineers there that I'm going to want to come back to this slide at the end in our discussion. Okay. Because what I'm talking about here is that hemoglobin is constantly going a little bit to the left when it passes through the lungs, and it goes a little bit to the right when it passes through the tissues. But when you have a patient who is blood, pH is high and you're alkaline, or a patient whose blood is acidotic, and the entire, body is stuck in an acidosis or in an alkalosis, now you've affected things in a dramatically different way because hemoglobin is not able to do the things that normally would do in a normal environment. You see what I'm saying?
Right. Yes. It should be able to move between these two states as needed.
So I want to talk about this later in the discussion. So let's go continue, but keep that in mind there. Okay. So in our conclusion, another golden nugget for you there, Joe. Oxygen dissociation curve. What is it? Summary, what we just talked about. It relates oxygen saturation to partial pressure of oxygen in the blood. It gives us a measure of hemoglobin's affinity for oxygen, meaning how readily hemoglobin acquires oxygen in the lungs and how easily it releases oxygen into the tissues that surround it. Hemoglobin is ideally and readily physiologically altered to benefit oxygen and carbon dioxide transfer from our lungs to the tissues. And factors including carbon dioxide, pH, 2,3-DPG, exercise, and temperature all alter hemoglobin's affinity for both oxygen and carbon dioxide. And these altering factors immediately tailor, meaning as soon as hemoglobin arrives in those environments, immediately tailors hemoglobin for its environment in the lungs, causing it to accept and bind to oxygen while releasing carbon dioxide, and then in the tissues to release oxygen and bind up carbon dioxide. All right, so now the next slides are going to go on their own, David. So the gem of the week, and as you guys know, we're doing this. This is a surprise. Could be anything. Could be a perfusion trivia topic or question. Could be tips on how to do a virtual interview now in the days of COVID. Top 10 ideas for interviewing well. Could be a great career opportunity, as we discussed in week 1, to come work with Joe there. It could be something happening in perfusion news, such as a product recall or any such interesting thing that is interesting to all perfusionists. Maybe we're going to talk about celebrating something during Perfusion Week, scholarships, a famous perfusionist retiring. We could just take a famous quote and discuss something intriguing about a famous quote. We could be talking about an upcoming meeting, such as the New Orleans Conference 2021 that Joe was talking about earlier. But this week's episode, Gem of the Week, is going to be quotes by Albert Einstein about knowledge and getting an education. Why? Mark Twain once said, "I never let my schooling interfere with my education." Next, Woody Allen said, "I loathe every day and regret every moment I spent in school." Thomas Edison, who actually did not like attending school, said, "I was at the foot of my class," the great Thomas Edison. Benjamin Franklin said about someone who was very highly educated, he was commenting about someone, he said he was so learned that he could name a horse in 9 languages, but so ignorant or had no common sense that he bought a cow to ride on. So let's look at what Albert Einstein had to say, and he had a number of quotes, by the way, not just one, about an education. And I want you guys to ask yourself and make some notes, if you've ever had a colleague, maybe somebody who you worked with, maybe somebody that worked under you, or just a fellow person who you grew up with, who had something to do with one of these quotes that Albert Einstein said. And was it a good experience or was it a bad experience? So the first one Albert Einstein said is, he said, "The more I learn, the more I realize I do not know." Meaning that the more educated you are, it opens up tons more doors and windows that you realize, oh my gosh, there's so much more to learn about this particular topic.
Is it the more educated you are or the more curious you are, so that the more you learn?
That's a good point, because we're going to expand right into that, Joe. Yep. So here it says, "Wisdom is not a product of schooling, but a lifelong attempt to acquire it." And Joe, I guess I should give you kudos on this one, because here's what you're doing on PerfWeb, right? You and I and Tammy, we've all been in this a long time, and we spend an awful lot of time continuing to search for knowledge in our own field. Number 3, Albert Einstein said, is education is what remains after one has forgotten what one has learned in school. Number 4 thing he said is, and you know, people are always telling Albert Einstein, "Oh my gosh, you're not so smart." And he finally said to them, "Look, it's not that I'm so smart, it's that I stay with problems longer." Meaning, I don't give up. I keep at it. I'm persistent. Don't mistake that for just being smart. Number 5, he said, the value of a college education is that it trains the mind how to think. And that's not something you can learn from a textbook. So now, those are 5 quotes from Albert Einstein, but I want to go with a few more famous quotes, just a few more, to give you food for thought. And these are just famous quotes in general about people who've had quotes about being educated or education. The great jazz musician B.B. King said, "The beautiful thing about learning is that no one could ever take it away from you." You've probably heard that one in your upbringing. Number 7, a great Chinese proverb. I love this one. It says, if you're planning for a year, sow rice. If you're planning for a decade, plant trees. But if you're planning for a lifetime, educate your people. Number 8, the great Carl Rogers, who, was, by the way, was a PhD psychologist professor and pioneered the humanitarian side of psychology. He said, the only person that is educated is the one who has learned how to learn, and then how to change. And number 9.
Uh-oh.
Okay, that's it. So guys, for everybody watching, there's my my email, john.ingram@perfweb.us. Email me with comments, questions about this show or other shows, suggestions for a future topic. And as I always say, I do and will respond to everybody who sends me an email to that email address.
And that's so fantastic. But go ahead. Were you closed?
And so basically, we're ready for the panel discussion, oxygen dissociation curve, and famous quotes about education.
So I really only have one question, and it has to do with one of your earlier PerfWebs that you did, where you discussed, clearly you're not in New York with that big drink, because you're not allowed to have big drinks in New York.
It's outlawed in New York.
You're in Florida. You know, it's more, Florida's way more progressive. If you want a big gulp, you can get one. You can't get one in New York now. But, no, you know that. You knew that, right? Yeah, they can't sell you, if you get a Coke like in the store, they can only sell you small cups.
Why?
Because the mayor.
The mayor? That's
yes.
what they say? Because
no,
the mayor?
At Bloomberg. I mean, this is real. I'm not kidding.
Yeah.
New York banned big gulps. You're not allowed to get
'Cause they're
giant
unhealthy?
drinks. Yes.
Right.
But I think that's what they said. But Bloomberg's a little fella, so he probably just couldn't hold a big gulp. So that's probably the reason. But anyway, but with that said, with that said, back to this. You gave a PerfWeb on metabolic alkalosis. Like, what is it? Why do we even worry about it?
Right.
And I'm
Good
sitting
point.
here watching this, wondering, do you know whether that permanent metabolically alkalotic condition just becomes adaptive? The hemoglobin adapts to it, because otherwise you would have this pretty strong shift to the left that would be continuous.
Well, actually, it's funny you said that, because that's exactly why I wanted to, I stopped on that slide and said I want to come back to it. So looking at us as perfusionists on pump or in the ICU later, whether it's on ECMO or not, you know, all of us have been trained to say, oh, the patient's acidotic. We have to, quick do something about it. But when the patient's alkalotic, oh, the patient's only alkalotic. Well, at least he's not acidotic. Well, let's not really worry about it. When you bring that slide back up, you're going to see why that is not accurate to say that.
David, can we bring this slide back up while we're talking? Thank you.
So, for people listening, and again, for our own benefit also, if you are acidotic, which means you are shifted to the right, that means that your hemoglobin, when it passes through the tissues, and passes through everywhere, by the way, if your whole blood is acidotic, it's very nicely letting go of its oxygen. That's great for the tissues, but when it passes through the lungs, it's not receiving and binding up the oxygen that it should be getting in the lungs. So you end up potentially with hypoxia in the tissues, because you're not getting enough oxygen in the lungs, although you're letting it go in the tissue. It's like half-empty coal cars, a train full of half-empty coal cars coming. Now, if you're alkalotic, okay, people tend not to worry about alkalosis. And by the way, when is alkalosis critical? I would say if you're at 7.50 and above, you need to do something about that. Just as a before we get off on this too much. But if you're alkalotic, which people tend to very seldomly get very excited about, you have an increased affinity for oxygen. So as the hemoglobin's passing through the lungs, it's attaching to oxygen left and right. But when it gets into the tissues, it's not letting it go. So now you have another, it's the same end result. You can have hypoxia. The bad thing about alkalosis is your arterial saturation looks great, and your venous saturations look great, because the hemoglobin's not letting go of the oxygen.
Stingy.
So you think you're great.
So basically, your O2 consumption, even though your requirement hasn't reduced, your O2 consumption reduces, I'll use the word artificially, but inappropriately. It's not O2 consumption decreasing because of decreased metabolic need. the metabolic need still exists, but your O2 consumption, because your hemoglobin's not releasing to the tissue, is changing, is
Right.
reducing.
So your venous saturation would still look
So
high.
you have a relative ischemia
Right.
Right.
without having a decrease in your saturations.
Right.
You're not delivering the oxygen.
Now, is
on the
that
tissue level.
adapted? Why I'm asking that question is, in a chronic metabolically alkalotic patient, you have this affinity, which is based upon a certain pH, PCO2, acid level, temperature, all of these various things in the lungs. So you're shifted to the left, so you have this increased affinity. And you may be metabolically alkalotic chronically, but in the tissue, is that difference that may naturally occur be sufficient to change the shape
To get
of
the
the
oxygen,
hemoglobin in order for it to release and not have, because if that was the problem, there's a lot of patients that live in chronic metabolically alkalotic conditions and they're still talking, walking, and living things. So is it the actual value or is it the differential? And then is there a tipping point where that differential isn't enough and you can get into trouble? See, I don't know the answer to this.
Well, the difference is, Joe, is that there is a difference, a big difference between acute alkalosis. If somebody comes into the ER and they're normally, physiologically fairly normal, and they come in because they've done something that's caused them to go into a high alkalotic state, they are going to be tissue ischemic and needs to be treated. Now, somebody who's chronic, as you've said, can be adaptive. And so there's some adaptive measure there that I couldn't tell you exactly what it is. Maybe somebody else smarter than me could.
We need to figure it out and do another program on that.
Yeah.
Yeah, that's a good point.
Adaptive metabolic alkalosis and adaptive metabolic acidosis, or respiratory. Because, of course, respiratory is different because you compensate metabolically, right? So if you have a chronic respiratory acidosis, you'll tend to have very high bicarb levels and try to get your pH somewhat normal. But what are those, where are those windows in patients with various conditions, especially something that is so sort of, ambiguous as chronic metabolic alkalosis? We just don't see it as a practice normally. We deal almost exclusively in the acute phase, but I know these patients do exist.
If you remember the PerfWeb you talked about, we did on this, Dr. Samir was on the panel, and he said, people come into the ER and they're acute alkalotic, which, by the way, is very common if in the cases of somebody who's got food poisoning, has been vomiting all night, diarrhea. They're going to come into the ER dehydrated, very alkalotic, and therefore tissue hypoxic. If it's somewhere in the 7, what did he get concerned, 7.55 and above, something like that, they want to start aggressively treating that in the ER?
Yeah, with some acids, fluids, acids.
Well, or you can give the diuretic that is a bicarb-sparing diuretic and things like that. I think they do.
Or you would have bicarb losing if you're alkalotic.
Yeah, you're alkalotic, so you'd be bicarb.
You don't want to spare. You don't want to spare it at that point.
Yeah. Right.
But is it respiratory? Is it metabolic? Hyperventilating. You could just acutely do that. Of course, you feel terrible. But there's so many other factors. There's cerebral vasculature changes from acute CO2 changes. And the question is it the CO2 or is it the hydrogen ions that are causing that vasodilatation and vasoconstriction? So, I think, and there's a lot of questions. We've talked about this before. Do you do pH stat or do you do alpha stat? Especially when you're doing, deep hypothermia circulatory arrest, which is the better option for that. There's just, it's such a complex topic, and there's a lot of different opinions.
There's so many moving parts that even one change in one part affects everything.
Yes.
As far as if you're trying to narrow down what the adverse change is predicated by, it's hard to even pinpoint that.
And I think that's why I said, if you remember the comment I made, what we do is an art form.
Yes.
It's just not an exact science.
Yeah, that's true.
And I think Einstein was right. We don't know way more than we do.
Right.
You know.
Well,
So-
I think it goes. You could even tie two of them together. That wisdom is knowing all the things that you might know, but there's so much more you don't know.
Yes, absolutely.
Yeah.
Recognizing that, I think.
Yeah, the actual recognition of it, right?
Absolutely. So, John, any final thoughts?
Yeah, I wanted to talk about this education gem, and the reason I brought this up is that I have encountered, I don't know, maybe you guys haven't, but I've encountered a number of people in my adult life who really, really talk down about getting an education. It's useless. Bill Gates barely graduated high school, and these crazy examples. People win the lottery also. So if that's what you want to base your retirement plan on, I guess you could. But the thing about an education, well, let me put it this way: a person who is uneducated can be ignorant about their ignorance, or they can be knowledgeable about their ignorance. There's plenty of people who will say, look, I barely made it out of high school. I'm not all that smart, but I know this. There's other people who think they know everything, right? The classic teenager, for example. And believe me, I was probably among the worst. I'm sure, Joe, you were more than a handful. Where
Not me.
You gained, no, not at all. You gained a little bit of knowledge, and you thought you knew it all, right? And so, that's what they say. A little bit of knowledge is dangerous because you don't know what you don't know. But then as you learn more and more, which rapidly happens, is that you expand what you don't know at tenfold, right? You learn something, but what you realize you don't know expands multiple fold. But people who never experience that think they have all the answers right there. And so, same thing with an immature person. An immature person acts immature because they're incapable of seeing their own immaturity. Because if they saw their own immaturity, they wouldn't act that way, right? If they saw how everybody else sees them. And sometimes an ignorant person who talks down about receiving a college education, it's a waste of time, and there is some truth to the fact that a formal education may limit your imagination,
Well,
a formal education may limit your imagination and may limit your creativity.
Well,
And all knowledge is not based in a college classroom by a long stretch.
It's not, but I think it's funny that people who want to use the Bill Gates example that, he barely got out of high school or whatever, that certainly may be the case. I don't know. I think that's what he says. However, he didn't stop learning. In fact, he's very learned. He was curious and continued to learn things outside of the classroom. That just wasn't the best environment for him. But people who are successful are going to continue learning no matter what their interests are.
Well, I just think, very quickly, we're sort of off topic here, but we're going to have a philosophical conversation. I think that there is I think that education and intelligence are exclusive of each other. So I think you can be highly intelligent but uneducated.
Sure.
But you can also be very well educated and completely unintelligent. So I just think that they're two different things.
Meaning lacking common sense, buying a cow instead of buying a horse.
Yes,
Right.
that would be, I think, a good example. But I do think that there are a lot of highly intelligent people who are also highly educated. I just think that everything we're talking about here is very mutually exclusive. But John, I don't mean to put you on the spot, but I'm not sure what the point was.
That was the gem, the topic of the gem of the week.
The gem of the week had to do with
education. So you got off topic up here. We stayed on topic.
Okay, all right. Well, good. Okay, so yes, I agree with you 100%. And if you really want to expand your mind, you need to attend John Ingram's Knowledge Nuggets every time he has one.
I'll one-up you. Maybe they should attend our spring conference.
Yes, you need to attend our spring conference, exactly, which is April 14th through the 17th. Don't forget that. But we do have a couple of programs ahead of that. Mm-hmm. One which is not yet listed, which is going to be listed, but Currently, we have the next PerfWeb 55, Tammy Sparacino Journal Club, and John Ingram Knowledge Nuggets on Thursday, March 25th at 5 p.m. Central Time to 7 p.m. plus or minus. And
We're always
then,
plus or minus, aren't we?
yes, and then we have a Wednesday program, which is coming up April 7th, and there's going to be a special surprise program, which is going to happen prior to that at 8 a.m. or 7 a.m., 7 a.m. to 8 a.m. So it'll be a surprise for you too, John, and for everybody out there. We'll be making the announcement, and we'll send out a flyer or something like that, so you'll get that if you're one of our subscribers. Go on Perfusion Education and get a free account so that you make sure, go to perfusioneducation.com. It's free. Sign up for a free account so that you get those notifications in your email, because we will send that out. Go ahead, I'm sorry.
I was just going to clarify. So April 7th, that's the Wednesday, yes?
Yes.
We'll have Journal Club, our normal time.
Yes.
But then we will also
Preceding that.
At 7 a.m.?
7 a.m. 7 a.m.
Central Time. We're going to have a special program.
That's right, which is going to become a regular special program.
Yeah.
But we'll make that announcement when we're ready to. We like to keep those cliffhangers. You know how we are. Okay, I think I'm going to bid everyone adieu.
Good night.
Miss Sparacino.
Good afternoon.
Yes, it's morning here, but good morning, good afternoon.
Covering all the bases.
Covering all the bases. John?
Good seeing you guys again. Great program, I think.
Yeah, that was an excellent knowledge nugget. It's my favorite so far.
Thank you it was very good. Thank you very much, everybody. We'll see you March 25th. Don't forget, become a subscriber, YouTube. Become a subscriber, perfusioneducation.com. It's a free account, and it really will help you a lot in getting notified about different programs we're going to have coming up with really expanded topics and expanded faculty, expanded places. You're really going to enjoy it.
And thank you so much for the case submission.
Yes.
Loved that.
Yes, and please follow up with us. We really want to know how that patient did. So if you would please send that to me, I would appreciate it so very, very much. Thank you all. Be safe.
Bye-bye.